A pleasure to introduce you again, the great Dr. Bijan BIJAN for second part of his lecture about COVID-19 features in radiology. And here we go, dear Bijan.
Okay, merci. Okay, I'm gonna start now. Yeah, this is the second part, this is part two of our series in COVID. This time we will talk about course of the disease, the way that the disease progress. So I see that in Paris, this is 9:30 in the morning. It's about 12 o'clock in Kabul, and it is past midnight in Sacramento, California. This lecture is going to be about 60 minutes. I want to thank our fearless leader, Dr. Azrin, for leading us this lecture series, and I'm very, very appreciative. I do not have any financial disclosures, and this time we'll basically talk about the course of the disease and what is important when we do imaging follow-up. And then if we get time towards the end, I can go over a few cases and do practice what we talk. So last time we talked about the fundamentals of imaging. This time we talk about the disease progress. So hopefully next time we'll talk about extrapulmonary involvement, coexisting condition. Then I have two talks on pediatric COVID and COVID in pregnancy. Then another two talk on treatment, follow-up, and complications. And then at the end, I'm going to have these two lectures on imaging safety and post-COVID imaging. So just to be very brief, I'm going to talk. I'm just going to give you a 5 minutes quick review of what we talked last time. Then in 20 minutes, I'm going to go over some of the clinical courses. In 5 minutes, I'm going to give you the conclusion, and then we're going to go over a few cases and just review all of the guidelines one more time. Very good. So let's start with a very quick review of what we said last time. So the three important imaging features that we pay attention to, number one is the ground glass opacity, that we said you can actually see the structure of the lung through that. It's like a hazy glass, basically. The second finding we talked about was crazy paving, which is the ground glass opacity with interlobular and intralobular septal thickening, give you this appearance of a paving, basically, like an old streets, the paving of the floor of the streets. And then the third finding was consolidation, which in the consolidation you cannot see the structures of the lung anymore. It's completely whited out. So how do they work? Ground glass opacity actually can be seen at any time during the disease, and most likely disease starts with ground glass opacity. It increases in the first 10 days, and then it hits a peak, and then after that it comes down. Crazy paving happens during the progressive phase of the disease, and consolidation seen at the peak and then slows down. So if you divide the course of a disease into four, like early stage, progressive stage, peak, and then absorption stage, and then we say like 0 to 4 days, 5 to 8 days, 10 to 14 days, and after 14 days, we're gonna have these four phases of disease, let's say. And so ground glass opacity, which is the blue one, you can kind of see it on all four phases. It starts early, but then it goes up and then comes down. But again, you see it all the way throughout the course of a disease. Crazy paving is a green one, which initially you don't see too many of those, but then it increases, makes a peak during the second phase, and then it drops. And the consolidation, which is the pink one, starts low in the beginning, but towards the peak of the disease, it goes up, make a peak, and then it kind of drops. So if you see ground glass opacity, you don't know where you are located. You can be very early or very late. But if you see crazy paving, most likely you are in the mid phase. But once you see consolidation, most likely you are towards the end of the disease. because in early phases consolidation, I don't say it doesn't happen. No, it happens, but it happens to the less, the frequency is less. So having said that, let's talk a few about this typical appearance of the disease that we talked about. So whenever we have findings in the COVID are not pathognomic, but they're typical. Now, what's the difference between pathognomic and typical? Pathognomic means when you see it, there's no other diagnosis. That's only one diagnosis. For example, if you see an inflamed appendix with appendicularity inside of it, and then a lot of stranding around this thing, differential diagnosis basically narrows to one thing. It is pathognomic for appendicitis, or the liver lesion, pathognomic for hemangioma. In the COVID, we do not have this pathognomic stuff. They're typical, but it's also seen in other disease. For example, influenza can actually have the same thing. SARS disease, well, we don't have too many SARS diseases anymore, but SARS disease can give you exact same appearance. So that's why we do not use the word pathognomic, or but we use the word typical. These are the typical appearance of the ground glass opacity that we see. For example, for most of them, they are bilateral, like this. We see it on both sides. They are peripheral located. They may or may not be associated with iridoid consolidation. Some of them, they're associated with minimal fibrosis. And then can it be unilateral? Well, in theory, yes, it can be unilateral, but unilateral disease happen early during the phase of a disease. During the late phase of a disease, almost 80, 90, 95% of them are bilateral. So this is classic or typical appearance of COVID disease. Now, there are other findings that are less typical, okay? Like those less typical ones are, for example, the central disease. This is supposed to be peripheral, like this one, not central. So when you see central GGO, that makes it less typical. We don't call it atypical, we just call it less typical. Or whenever you see this very, very small, like linear ground glass opacity area like this, these are also less typical. This is another example of the central one, or this is the example of the linear ground glass opacity. These are less typical. And then if I need to summarize it for you in one slide, I would probably say the finding that you really want to watch out for are ground glass opacity, which may have ill-defined margins, septal thickening, giving you that crazy paving appearance like this, bronchogram, and then a pleural surface thickening. So in in probably 30 to 60% to 80% of the cases, these are the features that you want to watch out for. So this is our main checklist. Less common features, there are those with a nodule, with cyst, bronchiectasis, pleural effusion, adenopathy. So these are the cases, stuff that you see 5 to 10% of the time. Okay, so if you read, let's say, 20 cases per day, you're going to see probably 1 or 2 or 3 cases at most with pleural effusion or lymphadenopathy. But once you see any of these findings, like sprained butt, mass, cavitation, or calcification, these are not typical. These are very atypical. You have to look for another diagnosis for these cases. Therefore, if you say, I want you guys to concentrate on these 2 sets of the findings to go in the COVID disease. And if you see any of these, look for an additional diagnosis. I'm not saying that people with cavitation or calcification, they cannot get COVID. Of course they can get COVID, but you have a coexisting condition. If I see a lesion, if I see a case with a suspected COVID case with cavitation and calcification, I would say probably tuberculosis, COVID superposition cannot be ruled out. I would probably report it something like that. So if I want to divide it into 3, the typical one was that ground glass opacity, which was typical, peripheral, bilateral, multilobar, multisegmental, which may or may not be associated with the crazy pipe paving and ground glass opacity and consolidation. And then reverse halo sign, last time we talked about it, atoll sign, which is a feature for organizing pneumonia. And these were the examples that we showed in the last lecture. Indeterminate findings are cases that are less typical, or these are the cases of, for example, unilateral or perihilar GGOs. They may or may not be associated with consolidation. And these are the examples of that. Now, a typical one, like the one that we talked about, are these. For example, if you see 3 in butt, you have to have different another set of diagnoses. If you see this kind of bronchiectasis with areas of cavitation like this big, then you have to look for another diagnosis. So these are atypical findings, very atypical. Therefore, you have to look for the alternative diagnosis. Now, this was a review of what we said last time. Now, let's start now. For the just to make this lecture easy, I'm going to divide the course of a disease into 4 areas: the preclinical phase, the first week of a disease, second week of a disease, and the third week of a disease. I'm not saying that disease can be easily divided into 3 or 4. This is just for the purpose of the teaching. There's going to be a lot of overlap. Some people, the phase 3 lasts for 2, 3, 4, 5 weeks alone. Some people, they just heal very quickly. So this is just for the purpose of the teaching. What are the findings we see in the preclinical case? In the preclinical case, why I call it preclinical? And when do we get there in these cases? Example, if a couple come to you and let's say the husband is coughing, you think I got a COVID disease, you scan the husband or you do the test, the husband is positive, and then the wife may be asymptomatic, but may actually force you to get a CT scan, the wife too. And then when you look at and the wife may be asymptomatic in the preclinical phase. Maybe the wife gonna get sick a week after. In those cases, these are findings that you may see. 60% of them they can be unilateral. 50% of them can be multifocal, and then in most of those you're gonna see them GGO. Things like septal thickening, pleural thickening, nodule, those kind of stuff, you don't see it often in the preclinical phases. Now, in the first week, what happens? The first week of a disease, that unilateral thing turns into bilateral. So at this 60% of the early cases, they may be unilateral, but now 90% are bilateral. Okay, so during the first phase of a disease, you are supposed to see bilateral disease. And then 50% they show diffuse disease. Still 80% of them they have GGOs. Findings like pleural effusion and adenopathy seen in 5 to 10% of those cases. So you're going to see 1 out of 10, 2 out of 10 of those cases may show pleural effusion or adenopathy in the first week. Now, in the second week, you will start seeing more consolidations. And once you get to the third week, you're going to see this reticular pattern. You're going to see pleural thickening as a feature. Other things like bronchiectasis, pleural effusion, adenopathy may also be seen. So these are a set of findings that you can see in each phase. This is a slide that I showed you before. So GGO happens in all 4 phases throughout the disease. The crazy paving, mostly seen in the second stage, but then the fibrosis or consolidation, you see it later on. So this is how it breaks down. Occasionally, you're going to see one of these cases that both lungs are completely wiped out. And this is a very, very bad sign. If you see it, it means that this patient is decompensating. This patient died after 4 days. Let's take a look at a few of these examples. This is the CT scan which was performed at the time of the admission. As you see here, on both sides that you have disease. These are ground-glass opacities. Some of them are associated with consolidation. You repeat the study after 48 hours. So this is how we have to give the comparison in our report. So the usual way that we, as a radiologist, you compare the study, the current study with the prior study, is you look at the number of the lesions. If the number increases, you call it worse. The second thing, you check the size of the lesion. If the size is getting bigger, you call it worse. But then in the COVID case, probably more important than the size and number is the architecture of the lesion. So sometimes the lesion gets bigger, but then the architecture changes. So in those cases, probably sometimes you're gonna call it interval improvement even. I'm going to show you a few examples of that soon. For example, in this case, you have only 3 findings initially, but now in this area, you're going to see new finding. This lesion increased in size, so that's also worse. And another lesion, which was almost non-existing, now actually you can start seeing the lesion. Now this one started with ground glass opacity, it changes into areas of consolidation. So you see, you have all sorts of stuff changing um, in this case. The size changed, the number changed, also the architecture of the lesion changed, which is important. This is a course of a disease. This is a day 3. This is the. I'm just going to give you a magnified view. This is what we call it crazy paving. So you have the background of GGO here, for example, and then you have this interlobular and interlobular septal thickening superimposed over that. This is usually seen towards the end of the first week. You see crazy paving. Later on, it changed into consolidation, and then sometimes it goes away by either leaving ground glass opacity or having hazy fibrosis. Now, I want to show you something here. In this case, the measurement of this lesion, probably that's how you would measure it. But what about here? This lesion goes from here all the way to here and this. So this lesion is much bigger than this lesion, but the appearance is different. So we should not really only go by size. Also, we have to talk about the appearance of the disease, the architecture of the entity. Take a look at this one. So when you want to give a quantitative measurement, be very careful about this. Otherwise, you're going to get a quick phone call from a referring physician. For example, in the first case, if somebody asked me to measure it, probably I will measure it something like this. Just get the whole thing into one area. This is how I'm going to report it. But if this is a follow-up after 4 days, now on the 4 days, I'm going to basically report one lesion like this, and then the second lesion like this. And I'm going to give you these 2 dimensions. Now that can be a problem because in your report, you're going to say currently 2 lesions are seen. So if the referring physician is not really reading your reports carefully, may think that that lesion actually got bigger. Well, in reality, that lesion is getting better. That's why it is like separating into 2 smaller entities. So this is important. We should not only check the size or check the size of the lesion, or only the number. We have to also pay attention to the architecture and the context of the lesion itself. So in this case, it would be misleading if I say that previously 1 lesion, now there are 2 lesions. Well, these 2 lesions are much smaller than that 1 big lesion. Take a look at this one, another example. For example, you see this finding in the lower lobe here, and the other part actually was normal. And in the follow-up, you see the progress of this. So the size is increased, the appearance is crazy paving appearance, and then you're going to see a new lesion here in the periphery, periphery on the right side. And here you don't see that finding. So this is a new finding. Just because, so in this case, this lesion is new, this lesion is increased progress. So you can actually call this progression of the disease. This is a nice example of atoll sign. Atoll sign is a coral reef. Basically, this is the lake, this is the ocean, and this is your crescent shape or round shape coral reef, which separates the lake from the ocean. Same thing here. You have this consolidation in the periphery of this, which separates this ground glass opacity from the periphery of the lung. Now, this is they say that the thickness of the consolidation should be over 2 or 3 millimeters, and it should encompass at least 2/3 to 3/4 of the lesion, the circumference of it. It can be completely round or it can be crescent shape. This atoll sign. Atoll sign is a sign for one of those signs that makes the lesion typical for organizing pneumonia. Take a look at this one. So this lesion, this patient got bilateral lesions, as you see here. So this is the way that we're going to report those two, give the measurements of those. But then but then there's a problem. On the follow-up, if you pay attention now how you're going to measure this lesion. So in this one, it's very easy. This is going to be my right side lesion. This is going to be my left side lesion. So here, this lesion actually is pretty big, something like this. So, and then this one also is involving basically most of the right lobe, and most of the left lobe, sorry. So how do you give the comparison to the prior study? If you give the size of this lesion compared to this, it's going to be interval worsening. But when you look at it, it doesn't really look worse. It looks like it's getting better. So in these cases, you have to kind of be very careful, not just give the number of the lesion, not just giving the size of the lesion, but also you have to pay attention to the structure, to the pattern of the disease. Most of these lesions, they like explosion. So it's a consolidation which explodes and end up in multiple smaller multiple smaller infiltrated areas like this one, and then by time it just gets absorbed and they go away usually. So in this case, as you see here, this thing is one of the lesions that are like literally exploding in the patient, and they're gonna basically absorb very soon. So this is a very, very good sign, although in the report you may say more lung involved. But this more lung involved does not necessarily signify this is a bad condition. Maybe it's just getting better. Take a look at this. This is almost unilateral disease. So so you have one lesion here, another lesion here. When you look on the other side, you can see this small, very, very faint, small lesion on this side. That was day one. Later on day 5, these GGOs now they are all come together, and there are areas of consolidation now formed. So the whole thing is like consolidated. Same thing I think is happening with consolidations. So in this case, once you have those ground glass opacity areas, now you have multiple consolidation, and then later on they start ending up with minimal fibrosis. This is an example of organizing pneumonia, and we know COVID is an organizing pneumonia. Take a look at this one. This is a crazy paving. This is a background of if you look at the background is ground glass opacity, and the septa thickening is superimposed over that. Those are the two types of septal thickening, interlobular, intralobular. Both of them are thickened in that condition. This is so the size of this crazy paving actually increased to a much larger area. Okay. And then this is the absorptive phase of the disease, and then later on you end up with a few small GGOs which are going to get absorbed even later on. In this case, take a look at this. This is day 8 of the disease. You see a few small scattered areas of probably ground glass opacity with superimposed consolidation. By time they kind of fuse together, and they develop like a one continuous lesion. By time they start getting absorbed, and by day 25, you see only a few scattered, very, very minimal ground glass opacity areas, which patient was resolved. So this is another example of the course of a disease. Now I'm going to ask you a question. If I show you this chest radiogram, just CT, if I only show you this, what would you say about the stage of a disease? Would you call this early stage of a disease or late stage of a disease? This is my point. GGO alone cannot put a date on the disease, because GGO can be seen early during the disease, in the middle of the disease, and also towards the end of the disease. So GGO actually can be seen at every phase. Therefore, based on the GGO alone, you cannot say at which phase of disease patient is located. Just keep that in mind. That was important. This is this is another case. The first one is 2 day old, day 2 of the disease. As you see here, there's a peripherally based pneumonia with a GGO and some reticulation. On 6th day, you see more GGOs and with areas of consolidation. And on day 7, um, um, basically all of those findings then be improved, and there are fewer lesions seen. Take a look at this one. This is a postpartum case. Patient has immediately after birth has all these GGOs everywhere, and after 10 days of post-viral antibiotic therapy, antibiotic therapy, we end up with this appearance, which shows marked interval decrease in size and number of the lesions, plus the appearance also has changed. Take a look at this one. These are 3 pediatric cases. In pediatric cases, uncommon features are more commonly seen. We don't know why. And in this case, you have a right lower lobe consolidation, example of that. But this was got a COVID disease and being observed for the COVID-related symptoms. Now take a look at the second one. This is only the interlobular septa um, are involved like this one. There's a 2-month-old kid. You see multiple areas of consolidation, and then you can see bronchogram, and then large pleural effusion here. So when you put everything together, it looks like COVID, but it's a typical COVID. This is one of those COVID that mostly seen in children and women. Take a look at this one. Occasionally, you see nodules in the lung, and during COVID disease, this is a case that after 4 days, the study was repeated. And as you see here, this nodule is increasing in size. Now, how do you deal with those? Do you want to get them, a 4-month follow-up, 6-month follow-up, 8-month follow-up? What protocol would you like to use? Well, remember this. If something is growing very, very fast, most likely it is not a viral disease. It's not even a bacterial disease. Very, very important. So you get the disease of your neighborhood. If you know your neighborhood, there's no cats and dogs, you're not going to get any cats and dog disease. For example, let's take a look at this one. The size of the lesion is increased significantly. Now, cancer doesn't grow this fast. Infection and inflammation, they can grow fast. So there was a doubling time of the cancer, for example. Doubling time of the cancer is between 100 and 200 days. I'm talking about the lung cancer. So if something is growing twice of this size, volume-wise, let's say in 100 days or 200 days, then you can label this thing possible cancer. But if the lesion is like doubling up in a matter of a week, not too many cancers would be able to do that, and probably cancer should not be on your list of differential diagnoses for those nodules. And this is an example. This turned out to be a COVID disease, and this is this patient had presented with nodules, basically. Take a look at this one, and this is this was performed in first day of February, and then this was performed after a week on the 8th of February. What you see here is a very nice classic appearance of a COVID sign, reverse halo sign. The center is a ground glass opacity. The periphery is consolidation, and by time, like in matter of a week, see what happened with the COVID disease. The disease actually like exploded a lot, right? And that's what happened with the COVID disease. So the patient who gets COVID disease, when they develop this halo sign explodes by time and develop multiple patchy ground glass opacity areas, and those ground glass opacity areas, they will go away slowly on their own. As you see here, this is another view of the same finding, which ended up in diffuse patchy infiltrate. in this case, we know it is going to be COVID disease. We feel kind of comfortable calling it COVID disease, but we know what caused actually this whenever they put you a picture in front of you, study, try to dissect all of the components one by one, because in one CT you may see multiple different findings. For example, in this one, you see some ground glass opacity areas up here. Then when you get into this area, this is like consolidation. This is a fibrosis. And in one of these cases, actually, patient had other findings too. It's important to look at every finding in two different views. You may detect them on the coronal, but definitely go back to look at the axial, because actually axial, if you look at the two different planes, then you can get a better idea at where this lesion is coming from or where this lesion is located. Example, where if I only look at this finding here, I would probably call I cannot call it very peripheral, because this is like away from the chest wall, for example. But then when I look at this coronal view, I see, well, all that finding actually is pleural based. This is based on the third part of the pulmonary parenchyma. And that's what it is. Another example is when you look at this lesion here, you have no idea how this lesion is located. But when you look at the orthogonal view, you see this lesion actually was a linear structure. So it's very important to look at the sagittal and coronal together. So how about this structure reporting that we've been talking about? There are a lot of pros and cons for structure reporting in general. As we speak, I'm writing a book for European Congress of Radiology on these structure reporting and application of that in imaging informatics. So one of the things that make people, structure reporting make people very lazy, because you just kind of look at it, you just kind of do a fill in the blank without even thinking too much. But again, it has a lot of advantages too. So everybody with any extent of knowledge, somebody may be at the level of a first year resident, somebody at the level of the third year resident, somebody at the level of the fellow, and then others. If they all use the same report format, then the referring physician would have difficulty understanding, so, okay, who was this one? Because they're not going to be able to remember like 50 names. So that's one of the things that I really urge people to be very careful to not only look at this, the way that they fill this form, but also who dictated the case, the names. Because like in this, like we had a case like not too long ago that the hospital asked us to set up the imaging center for them. And this imaging center that they asked us to set it up, we had some idea about this imaging center, but we the report format that we put there, these report formats, everybody can use them, and you would never ever know who actually used them. And then another thing is, once you have these report formats done, you can make a lot of mistakes filling those forms, and that's going to cause a lot of embarrassment too. So there are a lot of pros and cons. One of the advantages is all the reports can look alike. So this way, you can actually do research. You can search your report. You can look at, for example, all the typical cases or all the atypical cases. Also, the research can be done once your report system are unified. So probably the best scenario would be give the training and then give the report format. So Society of Thoracic Radiology, Radiology Society North America, and ACR, all of them, American College of Radiology, all of them, they got together and they come up with this list. This list is the list that can be applied only to patients who are physically located in the hospital. So those just be very careful about that part of it. So what are the typical findings? The typical findings are those GGOs, which are peripheral and bilateral multiple area. They may or may not be associated with consolidation or crazy pattern appearance. So how do we report them? This is the example of the report format. Is commonly reported imaging features of pneumonia are COVID-19 are present. So this is a sentence that we kind of use. This is a language that we use for typical cases. The second one is indeterminate. Whenever you see whenever you see there's an absence of all those features, for example, the unilateral, the perihilar only GGOs only. In those cases, you can say that these findings actually can be seen in the COVID disease, but they're non-specific and also can occur with a variety of other infections and even non-infection etiologies. Example, trauma. Atypical cases, however, they are different. They are atypical. These imaging features are atypical or uncommonly reported in COVID-19 infection disease. It's very important to report the cases like this because it's going to save you a lot of time for the follow-up, for example. Okay, so we talked about the first part, and now let's move to the part 2 of our talk. Let's take a look at this case. This is a 91-year-old male patient complaining of cough and fever. Okay, now that you have looked at it, let me just show you. This was at day 5 of the disease, and after 3 days, this is at day 8 of the disease. These are the changes. So how do you want to report it? So the way that we report it, we're going to call it bilateral GGOs. They're peripheral located, mostly they're posterior located. Also, on day 5, I want to pay attention to this area. This area is area of pleural thickening. That is also important to mention. And now on the day 8, you see most of these areas, they turn into patchy areas of ground glass opacity in the lung basis. Actually, the amount of those shows increase. This case has 2 teaching points. Number 1 is pleural thickening. You have to look posteriorly and posteromedially. May or may not even be associated with parenchymal disease. So, for example of that is whenever you if you say big GGO, doesn't mean you are gonna have more pleural thickening or pleural fibrosis. So it has nothing to do with that. These two are like almost separate entities. Another teaching point for this is even in the early phase of a disease, we can see GGO. Towards the end of a disease, also you can see GGO. So this GGO increase in the background of the liver, background of the lung, not necessarily the bad thing. This is a normal progress of a disease. So if somebody asks me how I report this, well, I'm gonna basically describe it. Multiple small patchy areas of ground glass opacity in the dependent portion of lung, and also a single one on the other side, on the right side. And if I have the comparison, I'm going to say interval evolution of ground glass opacity areas. I mean, in reality, I should give this measurement versus this measurement, which by time it increased actually by size. However, this is not a true worsening. This patient is actually improving. This is a natural progress of a disease. Okay, now let's take a look at this case. This is a case of 71-year-old female. Yeah, this is 71-year-old female with worsening oxygen saturation. I'm going to give you the video clip of it. Okay. This is the second. Okay, so this is the day 1 of the disease. We chose diffuse bilateral patchy ground glass opacity areas. This is the day 7 on the chest scanogram, basically chest X-ray. You're going to see there's an infrared worsening of these findings. And when on day 10, when you put them side by side, the lung is like whiting out. This is a very, very bad sign. This patient is actually worsening. This patient also got a few bronchogram. We talked about the bronchogram in the last lecture about a month ago. So air bronchogram can be seen up to 50% of the cases with people with consolidation or GGOs. One thing is, if you only see central lesions that usually carry a bad prognostic sign. Okay, so peripherally based ground glass opacity areas, they are typical and they are not that bad. But if you start seeing only central infiltrate or only central consolidation, that's usually a poor prognostic sign, something to keep in mind. Okay, case number 13. Let's take a look at this. So this is a 23-year-old patient with symptoms of flu. So on the day 11, these are the findings on the chest. And on the day 15, you see this faint ground glass opacity area now changed into areas of consolidation and maybe crazy paving appearance. So this is a normal progress, natural progress of ground glass opacity areas that are changing into consolidation. Okay, very good. Also remember that sometimes the clinician can tell you that patient actually is feeling better, and you're looking at your CT scan. Your CT scan look worse. There is a very loose relationship between what we see on the CT and what is patient demonstrating. So yes, it is possible that your chest CT may look worse, but patient feels better about breathing, for example. So that is possible. Keep that in mind. Okay, take a look at this case. This is a 55-year-old patient with a history of the head trauma. Okay, now whenever we have a history of trauma, that can confuse us. Yeah, when you have a history of trauma, you never know. What you're looking at is a pulmonary contusion, or you're looking at a COVID disease. And then you have to go back and check the history of the patient, exactly where the trauma came, which part of the body is more involved, and in this situation, looking at the mechanism of trauma, if this lesion that you're looking at can be related to patient's recent trauma. So in this case, what you can do short interval follow-up. Sometimes a contusion, they go away. Sometimes in association with contusion, you can see broken ribs, you can see subcutaneous tissue inflammation, those kind of stuff, and be able to make the diagnosis of fibrosis versus different diagnosis of the GGO versus lung contusion. So number one, the teaching point is important. Number two, if you do a follow-up, you see if the disease progress or regress is in parallel to a clinical finding. Also, apical segment, there are areas in the lung that are prone to other entities, like for example, the lung apices are prone to dune aspiration pneumonia. So be careful about those. Still, those cases that are happening, and they can actually show up in the hospital with shortness of breath, and patient may even try to give patient oxygen, for example. Let's take a look at this case, for example. This is okay. This is day 11 of the disease. So as you see here, they are bilateral patchy ground glass opacity areas. Many of them show area of fibrosis and dense material inside of them. So this is day number 17. So how would you report this? Okay. So day number 11, we're going to say the GGOs with areas of consolidation, especially in the lower lobes. And then number 17, we're going to say, well, those areas of consolidation um, 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 are mostly pleural based, and now you start seeing some subpleural bands. So that's how we need to put in the report. These subpleural bands are usually seen later during the course of a disease, not early. Okay, take a look at these two cases. I mean, this one case with two sets of images. Okay, so on the day 11 of the disease, this patient had fever, cough, and dyspnea. On day number 11, you see patient got bilateral patchy areas, they're pleural based, and mostly ground glass opacity. Some of them, they have calcification. And then later on the 22nd and 31st day, you can see this inflammation is kind of vanishing very slowly. So if patient got, let's say, if patient has 5 lesions, they may not progress at the same rate or go through the same pattern. I'm not saying it cannot. Yes, it can happen, but that's not usual. Usually, each lesion basically is governed by its own administration. They can sometimes show they can sometimes show um, 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 ground glass opacity. They can and then ground glass opacity can change into consolidation, but at the same time you have another consolidation which can turn into ground glass opacity. So it can actually go both ways. So it's important to look at each of these findings separately because they can actually evolve separately, and then also um, um, and also need to look at the clinical scenario too. Remember that the new lesions can still appear even if the patient is recovering. So if the patient is recovering and now from 4 lesions, now you have like 15 lesions, still that's okay. That can happen. So there's no direct correlation between the number of the lesions and the disease progress. This patient got diabetes, intrahepatic ductal dilation, cough, progressive worsening of that, 80 years old patient. Take a look at this one. Let me just give you the scene of these images. Okay. This is a day 11 of the disease. A little cardiomegaly. Here in the periphery, you see small area of ground glass opacity area. And on day 16, it got much, much worse. Now it's a bilateral disease. That small ground glass opacity area turned into marked bilateral patchy airspace opacities. And you get the air bronchograms here. You have all sorts of stuff, crazy paving appearance. This patient actually, it's very interesting that this patient developed pulmonary embolism. As you know, that also people with COVID disease, they can have PE. And actually, COVID predisposes to the PE, pulmonary embolism. COVID caused endotheliopathy. Because of the endotheliopathy, you have thrombosis. Also, it can affect other part of the cardiovascular disease. It can cause myocarditis, and it can cause all sorts of disease to the heart. That's a topic for the next lecture. Next time I'm gonna go over those with you. Uh, so um, so this was a case that this patient had when we see this kind of extensive disease, which is a little bit out of proportion, start thinking about pulmonary embolism. For example, this patient had a pulmonary embolism for each area that you see consolidation. Let's take a look at this case. This is the CT scan from day 2 of the disease. This is day 6. You see, there's this marked interval increase in the size and the number of the observations. By day 11, it's getting really worse. But by day 18, they start resorbing and having more aerated lung, So when you look at this, you know you're looking at the organizing pneumonia. And as we know, um, COVID disease is kind of organizing pneumonia. Okay, chest CT can be negative in 50% of the cases in the early phase. Keep that in mind. So doing screening CT over patient is not actually something that we recommend unless you're looking at a patient with high mortality or morbidity, like elderly, those kind of stuff. I'm going to show you actually this case. Um, mm, yeah, I want to show you this case. This is a very, very interesting case. So this patient, she come to the hospital, going for surgery. Patient was a little short of breath, so the CT scan of the chest was obtained. And they asked us, okay, patient, yes, is this COVID or no COVID? This was a day 1, which was completely okay. And then day 3, all of a sudden you end up with these diffuse patchy opacities everywhere. So what's going on? What is this disease? Well, let me tell you, this is a very, very nice case of fat embolism. This patient had tibial and fibular fracture, and because of that, developed fat embolism. Pay attention. The subpleural space is clear. There's no evidence of involvement here. This disease is more centrally. That's what happened in the fat embolism, for example. And the other inflammatory markers were not present. So don't get biased that every case that they're going to show you going to be a case of COVID. Still non-COVID stuff happens. There are some of them, they overlap in the findings with COVID, but again, you have to go through all those findings that we said, categorize it typical, atypical, and indeterminate. In this case, you cannot call this typical. This is atypical because these are not pleural based. These are not peripheral. These are not predominantly posterior. These are not predominantly lower lobes. Okay, so I think that was it. So just as a conclusion, the 3 important findings that we talked about are GTOs, consolidation, and fibrosis. We showed you this graph, which said that ground glass opacity actually can be seen in all phases of the disease. Crazy paving goes up and then comes down, and then fibrosis or consolidation goes up and then later on comes down. So these are, that's how they are. If this is important to say that features alone cannot predict the phase of a disease. So if the patient has ground glass opacity, you don't know if it's early phase or is a late phase. So be very, very careful about that. Another set of conclusion that we can get from this lecture is a GGO may actually change into consolidation and then lead to fibrosis. Now the reverse is also true. Consolidation can recover by turning into GGO. So it goes both ways. GGO can turn into consolidation and fibrosis. On the other hand, consolidation can actually produce GGO later on. So it goes both ways. Another thing is GGO can evolve into many things. Example of that was the crazy paving pattern, consolidation, can give you atoll sign or can end up with fibrosis. So this is the evolution of the GGO that can actually change into all of those findings that we talked about. The rare features like pleural effusion, pneumothorax, pneumomediastinum, adenopathy, vacuolization, those kind of stuff, in theory they can happen, but they're really rare. They're not very common. Maybe you've seen one patient out of 10 when you're reading those cases. So I think we are done with this lectures, with our lecture number 2. If there's any question, comments, suggestions, I'll be more than happy to answer. I think we
Thank you very much, dear Dr. Bijan. So if you have any questions, go on, please.
I want to give credit to Dr. Safid Bak. She was my partner in preparing these lecture series. She's from Shiraz University, and basically half of these cases, half of this effort is related to her. So
your nice presentation mentioned regarding all the findings of COVID in chest CT, and its different patterns, different stages, and also you mentioned regarding the differentials and progression of disease and also regression of disease. So my question was about protocol regarding COVID patients, and can correlation of X-ray findings and chest CT findings in COVID patients and different stages, and how about the patterns and X-ray?
I'm sorry, can you repeat the Arshid, can you repeat the question? I didn't get it.
What is your departmental protocol regarding COVID patients CT? And the second question was how about the correlation of X-ray findings and CT findings in COVID patients?
Oh, the correlation between CT and chest CT and chest X-ray. Well, if you have positive chest X-ray, there's no point doing chest CT. So you can save money, you can still save the patient radiation. Bring the patient down is very difficult during the COVID time, because each time you bring the patient to the CT scan, you need to clean the CT. And some of these COVID cases are not very healthy enough to go for the study. So if you can do the chest X-ray, and chest X-ray give you the finding, we usually stop there. For the follow-up, chest X-ray actually is a very good test. I personally prefer to, if it's just a routine follow-up, like let's say patient is in ICU and you're following patient, so every day you get a one chest X-ray, that would probably be good enough. Now for the for the patient who are less severe, they're not in the ICU, they're in the regular floor. So for those cases, they usually go with the oxygen saturation. So they check the pulse ox. If the patient is deteriorating, then they want to figure out what's happening. If the patient is really getting worse or not, then they do a CT scan. Also, there are going to be new guidelines that what they really want us, to report on the chest CT. So based on the chest CT parameters that we are providing, they will decide how to treat the patient. For example, they're going to intubate the patient, or they're going to give a CPAP, for example. Now, as we know that many of these cases are being treated by CPAP rather than intubation and putting them on a heavy-duty ventilator. Short answer to your question would be yes. If the chest X-ray is showing the finding, that's good enough. If the chest X-ray is not showing the finding and patient is especially is a high risk, like kidney failure, oncology, cardiopulmonary disease, pre-existing like stroke, hepatitis, cirrhosis, those kind of stuff, old age. These are like comorbidities. If you have that list, I showed that list of the comorbidity in the last lecture. If you have any of those lists of comorbidity, chest X-ray is normal, go for chest CT because these are high-risk patients. You don't want to miss the diagnosis. Chest CT, of course, is better than chest X-ray, but it's not necessary once the chest X-ray is positive. I don't know.
You were speaking about Bijan and John. You were speaking about their recommendations. They want us still to have one CT, chest CT at least.
Okay. Okay. Yeah, it's a very good idea to have one chest CT, but I can tell you that we have the patients that are outpatient. They come, they get a chest X-ray, they cough a little bit, they don't do a CT scan, they get some medication, palliative, conservative medication, they send them home, and they don't do a CT scan. Many of them they get discharged from the ER directly home after one chest X-ray. Yeah. I mean, they basically go with the oxygen saturation. If patient is not heavily desaturating, they prefer not to do.
That's true, yeah.
But I mean, we have to save money. No country is rich enough to spend all of the money and resources on this COVID. I mean, COVID is already putting a lot of financial pressure over every country in the world. No country is rich enough. So we have to kind of save money. We don't need to CT too much.
Of course, yeah.
Thank you, sir. I have also a question. Thank you for your nice presentation as well. I'm Dr. Naqib, radiology resident. Once I saw an Indian professor using the chest severity score, CT severity score in a patient with typical chest CT features, but however, it was not confirmed by the PCR. So my question is, can we use the chest CT severity score for suspicious patients who are having typical features of COVID-19? However, but they do not have any confirmation regarding through the PCR.
Yeah, you know what? I used to use the chest CT severity score, but our pulmonologists, they told us that we don't really care about that. Don't put in the report, and because that was one of those standards that was given prospectively, were proposed, not retrospectively. That was not based on any real data. That was like somebody came up with this formula. So, well, can we score everybody like this? Probably it's a good thing to know about that, but in my institution, we are not using it. Arshid, are you using them?
I don't know. We are not.
Well, we were using them when we had COVID, but we haven't had any COVID since months now. But it's starting again in Paris. Actually, we have new cases this last days actually coming in France again and in Paris again. So I know that in Iran they have a second peak, but we haven't had any cases for months. So at that time of the first peak, we were using, of course, these scores, but I completely agree with you. It was based not on evidence-based knowledge. So yeah, maybe we can change this severity score with some new data, or as you said, maybe the people, colleagues from ICU or pneumologists don't care at all.
Yeah.
But we were using it, but I'm not sure. Maybe in the second peak.
I have a question, Dr. Bijan. Sorry.
Yeah.
Sorry, Arshid. Sorry. Dr. Bijan, can you just describe the number of the severity, or compare the numbers and the severity of April and May and today in your center? It's decreasing the numbers, it's increasing. What? Can you just give us a picture of what's going on, please?
Well, back in, I think that was April. In April, we had a lot of cases. Then it dropped for a while because we basically shut down California for weeks. We didn't have, because of the shutdown, and people really were taking care of themselves. Nobody was coming out. All the restaurants were closed. Everybody at home, masks, everything. And so that helped, and the number dropped. But then we ended up with this thing, which we call it quarantine fatigue. So people really got sick of it. And now everybody decided to go out, go out, eat out, go on the street. People are sick of masks. So all of a sudden, people start partying outside, and the number increased again all over again. So in California, we are experiencing increasing number, unfortunately. I expect we have another peak going for this peak.
Hello.
Last for another month. Probably going to come down and then going to go back up probably early fall. I would say September, October probably will have another peak. It's going to be like that. It's going to be up and down, up and down, up and down. As long as we don't have a really, really a big peak, I think we'll be okay. And we're going to go through this up and down, up and down. Something to keep it under the threshold of what hospitals can afford. Like, for example, we used to have 15 ICU beds. Because of the COVID, we increased the number of the ICU beds to 45. And we canceled all of the elective procedures. Guess what? We had only 5 cases of ICU filled up. So we have 45 beds with only 5 patients. And that actually bankrupted the hospital because they didn't make any money and they shut down all the whole thing. So as long as we keep the demand under the supply, we are fine. The worst thing is you basically open up and people start going to restaurants and hotels and take a flight and all sorts of stuff, and then you have a huge peak beyond the ability of the hospitals to cope. So, and I don't think any vaccine going to come out anytime soon, honestly. It's my personal belief. Treatment probably going to come out, who knows, maybe in the next 6 months or so. Vaccine is probably 1 year, more than a year away, a real vaccine. So really we have to take care of ourselves and tell the people to stay home, use mask, don't do any dangerous contacts, do the social distancing. Of course, people are going to get sick, but the number of the sick patients, you want to keep them low. So it won't this is the line. You want to be here, hover here. You don't want to hover. Because once you go above that line, the mortality increases because these people, they're not going to be able to get adequate care. This is my recommendation.
Okay, thank you. I have also one more question we had a few patients here, COVID patients who had chest CT scan and were confirmed by PCR. And for the follow-up, when we saw the images after some 2 to 3 weeks, after they went they were not symptomatic. So the chest CT scans were showing honeycombing. So the fibrotic pattern of the patients with COVID-19, is it always honeycombing or does it have any other pattern as well?
I'm not sure if I understood the question well. So you're asking in asymptomatic patient what the findings can be?
The patients were known cases of COVID-19 and they recovered. Yeah, known cases of COVID-19, they recovered. So for the follow-up imaging.
Oh, recovered. I see. Okay. Yeah, you know what? We don't know we don't have any experience with that because COVID is less than 1 year old. So we don't know what the long-term findings going to be. My guess is they're going to be some fibrosis, but many of that fibrosis actually they are resorbing. This is our experience. So probably those fibrosis will stay in the periphery of the lung, and who knows, 10 years from now when you scan the patient, you say, well, probably this patient had COVID disease back in year 2020. Now, another thing is, it's just like tuberculosis. You look at this, look at the CT, you just say, well, this patient probably had tuberculosis. When you look at these CTs, the COVID cases, a few years from now, you probably say this patient probably had those fibrosis, classic fibrosis in the inferior and posterior. Now, there's one more thing I want to point out. Now, you're going to see, we are seeing a lot of ground glass opacities these days of the COVID cases. Some of these cases probably are bronchoalveolar carcinomas, because nobody is making diagnosis of bronchoalveolar carcinoma anymore in the setting of the COVID disease. I want to propose all of the cases of the COVID cases come back after a year or so to get another chest CT to make sure that we are not missing any bronchoalveolar carcinoma in these cases, because we know some of these ground glass opacity areas that we see in even COVID cases are bronchoalveolar carcinoma. Otherwise, we would call them, I mean, if that was like 5 years ago, if I say ground glass opacity area, that would be my differential diagnosis. And I would probably bring the patient back after 6 months or a year to repeat the study to make sure this patient doesn't have a cancer. We are missing a lot of those. And I don't know what to do with that. How can we justify to do a CT scan on all of these cases one more time? So that's something that probably in near future, maybe in a year or two, we should, it will be addressed. I guarantee you that somebody will address that. But we don't know yet. We don't have any protocol for that, and we don't know how many of those cases we are missing.
Thank you, sir.
Okay, I think this is 1:45 for me.
Yes, a very, very, very nice proposition. Indeed, because it's true that you are missing, and even patients sometimes now are more happy if we tell them that you have a bronchocarcinoma rather than COVID. You don't have COVID. It's when do you propose to inject?
Okay, I don't know. Recently, all the cases I'm getting from the ER, they come as a pulmonary angio. I think somebody gave them some lecture, so they completely switched to contrast enhanced studies for COVID. I don't have a good answer. I don't. I mean, this is something that I recently noted that all of the cases I'm looking at are contrast enhanced. I don't know.
Yeah, it's not easy. Mostly that there are also some new findings that you have microvascular disease coming with this, and perfusion troubles. So sometimes they even ask for spectral. But
the COVID caused basically immunologic endotheliopathy. And it goes and is everywhere in the body. It is in the GI tract. That's why some people, they develop abdominal pain, go and present with diarrhea. That's why some people show up with the abnormal liver function test, because they get that thing in the hepatic vasculature, cause hepatitis. That's why some of these reaction endotheliopathy happen in the kidney. That's why they end up with kidney failure and nephritis. Also have in the brain, it causes encephalitis. Having the olfactory nerve that can cause that is causing an anosmia. So yeah, and then the lung disease, the part of the disease, I think also is part of this endotheliopathy rather than primary disease. And that's why the inferior part of the lung and posterior part of the lung are affected. Why? Because you have more blood supply to those areas. So if you're gonna have an infection, if you have an inflammation, immunogenic inflammation going on, you're gonna have it in the inferior and posterior aspect of the lungs. I don't think it has anything to do with aspirating the droplet. I think it has more to do with immunologic response that we see in the lung. Most likely that's what it is. So yes, this is systemic disease, and the basis for that is immunologic endotheliopathy. Yeah.
So I'm sure we are going to disturb you again sometime.
Oh, absolutely.
I think it's 1:30 or 2 in the morning in
1:50, yeah.
At 1:50. So maybe we will let you sleep, have some rest.
Okay.
I know that you were on duty these last days, and thank you so much. Thank you very much for your lecture.
It was my pleasure.
It's always really very clear. and the teaching points are brilliant. Thank you so much.
Absolutely. Thank you. Thank you, everybody.
I apologize on behalf of Dr. Zans, who was unable to do his lecture last Wednesday, was it? And we're going to postpone his lecture, and I will inform you. The next lecture is Professor Renaud from Bijan Hospital, speaking about liver lesions that that have been fortuitously discovered. And that is Wednesday, the 29th of July. And we will speak again with Dr. Bijan for to be continued.
Okay, sure, absolutely. Okay.
Thank you very much.
Thank you. Bye-bye.
Khuda Hafiz.
Khuda Hafiz.
Khuda Hafiz.